So when I'm going to talk about injury prevention youth today, I'm going to kick off with a little narrative. We're going to listen a little bit from Emilia, her story.
My name is Emilia. I'm 15 years old and I love football. This season has been amazing. I'm playing games with both the original team and the women's team, besides my old team. The coaches really believe in me, and it feels great. It's a matter of keeping up with school, practice, and friends. This semester is really bad so far. I've got so much to do in school, homework and exams every day. I hurry home from school to football practice every day. No time to eat. Games every weekend. The last practice, I was hit on the head. I didn't say anything. Now my head hurts like hell. Saturday, game with the women's team. I still feel really bad. My head is about to explode, and I haven't slept for ages. The coach says she really needs me, so here I am, just warming up. 30 minutes into the game, I'm completely off. It's gonna clear the ball away. Oh! What was that? My knee just exploded. Went to the hospital last night. It was all swollen and the doctor took blood from the knee. He said it was excruciating and that I needed surgery, at least if I wanted to keep playing football. If I wanted to. Oh my god. He said no football for at least a year. But Mom quit after a cruciate year. Bye-bye, Magic Team.
So I think many of us in here have heard stories like this from our patients and maybe even someone we know. And with all the things we've talked about ACLs and the poor outcomes we have after ACL injury and surgery, I think we can all agree that prevention is really the key for these young athletes. So let's rewind the tape a little bit and look at Emilia's story and see if there are any clues on how we could actually have done something to prevent this injury from occurring in the first place. So if we look at her story, we can see that just the fact that she's a teenage girl playing football, this is a high risk. In her puberty, and also there was an heredity issue, a mother, we spoke about that before. We've seen in the data from the knee control study that actually if you have a sibling or a parent with an ACL injury, you're 4 times more likely to have an ACL injury. So there's definitely some kind of genetic, hereditary thing going on. A lot of matches and playing matches with the senior team. We're going to look a little bit on this. This could definitely be a risk factor for Emilia. Stress, not having enough time to get back and have a meal after school, just hurrying home to the practice every day, playing games every weekend, no time for school, no time for social media and so on. Or a lot of time to that actually. And also playing with an injury, playing with some kind of ongoing symptoms. These could all be potentially risk factors that we could have worked with Emilia. Now, we all know that this sort of awkward teens that we call it is associated with an increased injury risk, and particularly for ACL injury, as we can see. There's a lot of stuff going on in the body, there's hormones and everything, socially, psychologically, trying to fit in, trying to become a young woman. This is a picture of what happens in the body, in the growth spurs that Emilia just probably gone through. It peaks around 12, 13 years old for women. And we see that when you come just after this period, after sort of end of puberty and after puberty, you have the long femur and the long tibia with long lever arms around the knee. You gain weight, so there's higher forces also on the knee. Maybe you you start to play more intensive games and so on. So these are all risk factors for ACL injury. And this is data from the knee control study. And you can see here, these are the acute knee injury incidents overall, and the gray bars are the ACL injuries. And you can see definitely there's something happening here between 14 and 50. The injury rates go up substantially. So this sort of correlates with the period that Emilia was in. And we can do some simple testing, trying to look at the neuromuscular function around the knee with these simple hop tests, for instance, if it works. You could definitely say there's something a little bit different with the girl on the left to the girl on the right. And it's not as simple to say that she will go on and have an ACL injury. It's not that simple, we all know that. But could it increase her risk? Potentially, yes. Now, I'm not going to talk very much about neuromuscular training. We all know this in this room. Neuromuscular training works to reduce ACL injuries. It works to reduce the number of lower limb injuries as a whole. And a recent, very large meta-analysis from Hewitt and the three teams show that you can expect an overall ACL injury reduction of 50%. And for females and non-contact injuries in particular, 67%. 67% injury risk reduction if you do these programs. So they really should be mandatory in all youth team sports. These are some of the components that you really have to think about in these programs. Do them several times per week. These are the components you have to include. You train the full season rather than just training during the preseason, for instance, and keep the compliance up. Those are key factors. Now, the injury risk in match play is 10 to 15 times higher for an ACL injury. So the games are the big problems for the youth players. So it makes sense, if you play too many games by itself, you're at a higher risk of injury. And again, in the knee control study, you can see that 1/4 of the girls actually played games with all the teams and senior teams. And when they played those games with the senior teams, they had double risk of knee injury. So even though we don't have level 1 evidence here, it definitely makes sense to say, limit the number of games the youth play, limit the exposure to senior team sports. Now, there's several studies on workload and relation to injury. I popped 4 of them up here because they are in youth sports. So this is from the Swedish sports, Riksidrottsgymnasium, the sports gymnasiums, von Rosen's work. There's from football, there's some nice studies from handball, from Denmark, Norway. All of them show that there's definitely a correlation between having a high workload or a peak in workload and injury. Again, we don't have level 1 evidence from RCTs. I know they're working on this in Norway, we're looking forward to that. But again, there's a substantial amount of evidence to say that this is something we need to consider. So how can we measure it? Well, we can count the number of games, the external load, the number of trainings and so on. But importantly, we can also ask the athletes, how do you perceive that load? With a simple question like this. And this is really, really potent when it comes to sort of looking at the load for that athlete. The rate of perceived exertion. Well-being and injury, there's also accumulated evidence that the sleep, stress, sort of mood changes correlate to injury risk. There's even level 1 evidence from trials, intervention trials, that you can reduce the injuries with CBT-based interventions. We don't need to be psychologists, but we can use these techniques as physios as well. Now, playing with injury, we know that a lot of youth athletes play with symptoms. This is from a floorball trial that we have just done in Sweden. This is from Norway, from the Idrottsgymnasium there for the youth. 40% train and play with symptoms. It's quite a high number. We know from the knee controls trial that if you have ongoing complaints, you are at an increased risk of knee injury. So how can you measure this? Well, a simple tool to use is the Oslo Sports Trauma Research Questionnaire. Just 4 questions, do that regularly, and you get a good picture. So, to sum up my speak, these are the take-homes. You really need to do neuromuscular training. It's a vaccine against injury, and it should be mandatory for all youth team ball sports. Limit the number of games, and especially games with senior teams. Respect minor complaints and act on them. Monitor workload, well-being and health. You can do this with really simple questions. And be prepared to act on that information. If you have a very stressful week, a couple of weeks with a lot of exams in school, a lot of things going on, social in the family and so on, maybe you don't have to train for 2 days. You can just skip those training, be a little bit stressed. Thank you.
Thank you, Martin. And we give a word to Grete from Norway, and she's been spending a lot of time, a lot of research on prevention. Let's hear what she has to say.
Hello again. Now we are going to talk about the most important thing, I think. How can you prevent them? Because I don't think we're going to be afraid that we don't get patients if we prevent injuries. Anyway, if we only meet the patients after their injury, we can prevent the re-injury. But I think the most important thing here is to try to prevent the first injury. And we as a group is important there. Our question is, how can we keep our players healthy? And today I wanted to sneak in some more than ACL, so I also included something about the shoulder. How can we prevent shoulder injuries in handball? And long time ago, we did this prevention study in female elite handball players in Norway. This was a study where we tried to improve the neuromuscular control in the knee, doing a lot of balance exercises, some strength and jumping exercises. And what we showed was that, maybe the most important point was that those athletes at the elite level who didn't do this program during the whole season, they had a 16 times increased risk of getting an ACL injury. So this program actually prevented ACL injuries among a lot of these Norwegian female athletes. And some of the exercises were like this. We tried to do some perturbation training. So they should practice a 2-feet landing after a push. And we know that there's a lot of situations in handball where this happens. So this was one part of the program. Another part was doing running exercises and just warm up the knee before they are going to do their handball practice and team play. So just doing this more or less running and stabilizing the knee to get this knee ready for doing the cutting movements. And as you saw, this really worked. Approximately 40% reduction of ACL injuries in elite handball. Then we did this study. This is also in handball, but in youth athletes, both girls and boys. This was a more structured warm-up program. And this was a 15-20 minutes program with running exercises, technique, balance, strength, and plyometrics in a randomized control study. And the results was really good. We had a 50% reduction of lower extremity injuries. And regarding ACL injuries, it was really good. The control group had 10 ACL injuries versus 3. So doing a structured warm-up, that means it's nothing special. You do running, you're doing strength, you're doing balance, and technique training. And the technique training is trying to land on 2 legs with flexion in hip and knees instead of 1 leg, out of balance. And the other thing, trying to make a little smaller cutting movement. Don't do the cuttings of hair. Try to be more narrow, and then you need more strength. So that was the main point. And it worked well. And recently this study is published just some months ago. This is also a study among handball players where they did neuromuscular training for 1 season. Hamstring strength, single leg jumps, jump and landings, and single leg balance exercises. And as you see, the conclusion, the neuromuscular training prevent knee injuries, and it should be implemented in regular routine as well as in coach education, were their conclusion. So, as in football, we know there are programs that works. Regarding the ACL female program, we wanted to follow these teams for many years. So this was the control season where we had about 0.5 ACL injuries per team per season. Then we had the 2 intervention seasons, so we had this reduction as you see here. And then we continued. We draw from the teams, so now it was up to the team to do the training themselves. Then you see what happened. It just went up to be getting even worse in Norwegian handball, female handball. So then we tried to do something. We included, started the website skadefri.no. We had this youth prevention study which I showed you, and then we followed the ACL injuries among these 3 upper level in Norwegian handball for several years. And as you see, we managed to reduce the number of ACL injuries in Norwegian female handball with 50%. What the number are today, we are not the exact numbers, but I hope to come back and give you some more information in the handball congress in November, December. So please come in to Copenhagen and see there. So we actually saw that this is something that works. But how can we get this out? Because this is the main persons. It doesn't help the players if they don't do it. And if we don't get a coach on the team, it won't work. So the coach asked me, what is it in for me? Is it any reason that I should do it? Then I tell them, this is the state for ACL injuries in this 99-2000 season. There were 12 ACL injuries. That means 1 player ruptured their ACL on each team every year. So each team had 1 ACL injury in the elite level. After doing the prevention program, it's halved. So it's 0.5 injuries per team per season, which should be relevant. So we had a 50% reduction. So the coach also wanted us to say something about shoulder overuse injuries. And how common are the shoulder overuse injuries in handball? We know that during 1 season, 8 to 10 players will have a shoulder problem in handball, both male and females. But, so half of them will have, and at any time we ask them, 5-6 players will have a shoulder problem at any time in the season. So after doing this prevention program, which includes exercises like this, trying to do something with external rotation strength, and this doesn't work, but they did throwing the ball back, so you activate, it works good. You activate external rotation, and we did a lot of pair exercises. Let me go further. No, hopefully, no, we didn't. Yeah, doesn't matter. We can go further. Behind this video, there's a full training program, but we can stop there. So if you want to see the training program that we use to try to prevent overuse injuries in the shoulder, you can look at this article by Anderson et al. And what happened after doing this prevention study for 1 year, he reduced the number of overuse problems in shoulder with going down to 3 players instead of 6. So this really worked. 28% reduced risk of getting an overused injuries in the shoulder, which is important for handball players because there's a lot of shoulder problems. So going back to the coach, what's in it for me? Well, 1 point you will have available players, both less shoulder, less knee problems. They will be more 100% ready for training and matches. You can improve the team performance by having the players there, which is really important. And then the players also ask me, why should we do all these quite boring exercises? They also ask, what's in it for me? Well, you can train and play matches, and you are more or less 100% ready to perform, and you can develop as player. If you are training and playing, you can develop. If you're sitting doing rehab, you are not developing much. And you can have a longer and a better career. So, what we are talking about ACL injuries, which is the main talk today, what works? And we know that all this stuff works. Strength, coordination, neuromuscular training, technique training, running exercises, and plyometrics. This works, and if they do this type of training, you get a risk reduction. We can't prevent all injuries, but we have a risk reduction, which is important to keep in mind. And I do think that the coach and athlete is so important. If they are not eager on this, it's really hard to get this out. We need to get them out to do this and help us do this training. And also, as Martin talked about, the load management. Should athletes be allowed to play on several teams when you are 14, 15, 16 years old? The best ones are playing on several teams. They are vulnerable to get an ACL injury and other injuries as well. Should we reduce the number of matches allowed for that age group? I think so. And do they get enough restitution and rest? Do they get the right nutrition? I don't think so. It's a really tough time for exactly what Martin showed us with this girl. So I think we need to keep this in mind. And another thing, how do they use the training time? Warm-up time in teams. If you have 3 sessions, it's about 60 hours per year. If you're doing 4 sessions a week, you have 80 hours every year. 5 sessions, you have 100 hours warm-up time during a year. And we can ask the coach, can you use this time better? Why can't you introduce all these exercises that we know works? So we have to push this to the coaches. And just to give you an example of a warm-up, this is a warm-up that some of the national team uses now and then. They don't use it every time, but this is a part of their warm-up, if it will work. I'm not sure if it wants, but it's working hard now. Come on. There. So this is some of the exercises they include when they do warm-up, and you see this is very slow motion again, so it's usually a little bit more action, but can you recognize the running exercise to warm up the knee? Forward, backwards, rotation, sort of lunges, but also doing stretching, giving rotation for the thoracic mobility. And again, you can see they are trying to warm up their hip, knee, ankle by doing lunges in circles. And I know that they don't think this is the most fun warm-up. They would rather play football or basketball, but you shouldn't warm up with football and basketball when you play handball. And here you see the trying to have control in more of one leg landing or cutting movement. So making the body ready to do cutting movements. And increase the speed. Using their feet quite more and more quick. And all the time control. And then they have shadow exercise. Then they really increase their footwork, which is good. And so regarding the first slide, we can reduce the risk of shoulder problems with 28%. We can reduce the number of ACL injuries with 50%. And I think that is really important to keep in mind. And for those who don't have this app, Skadefri, because if you know Norwegian, it's easy to download this app for free. There are all Olympic sports. There are exercises for all Olympic sports. So you can pick your sport and find exercises for it. We also have a website called skadefri.no, and in English, Get Set, Train Harder. Here all the Olympic sports are there with exercises for all sports, and it's free to download. There is one exercise I didn't mention, which I think is important. It's an exercise to increase the strength of the medial hamstrings. So doing the kettlebell exercises to really get the pre-activation of the medial hamstrings, which is really important in prevention of ACL injuries. So that was the main point. So go out and prevent. Thank you.
Thank you very much. How many of you in the audience have met young athletes playing on several teams? Hand up. It's 105%. So there's a lot of things what can we do about it? Think about that, and I'll ask you again later on today. Now we're going to hear Marcus Holén about prevention in elite football.
Thank you, Roland. Sit down. Do you? No. Good. There's my slides. And this is the last for me here, so I would like to say thank you once again for having me here. And I said to Roland yesterday during the dinner that I was really impressed by the studies in the free paper session, and I would also say now, really good, interesting studies. I don't know if you're out there. And I know you have very high demands on yourself, but remember that you're much better now than we used to be back in time. You're better in English, you have better presentations, you have better studies, so never forget that. I will go to my talk here. It's about injury prevention in elite football, and it's a little bit different than the previous talk by Martin, more similar to Grete's, but from a football point of view. And I showed this yesterday. I just want to say a few words. This is a classic, quite simple model. Now there is an extension of that model, newly published in a Science of Medicine in Football journal, called the Team Sports Injury Prevention Cycle. And that is a little bit more convenient for the situation in professional athletes, perhaps. Because, are they the same? Those 14-year-old female football players doing knee control here, and this 33-year-old guy and his teammates. Probably not. If we use knee control as an example, if we introduce this in the 14-year-old football players in Sweden, we can see that they are doing these typical exercises, and maybe if they do the exercises properly and during a longer period with high compliance, we can see these substantial improvements in the exercises. However, if you introduce a neuromuscular training program such as knee control in Ronaldo and Dybala's team, we won't see any gain at all probably here, because they are already doing these or similar exercises. They are so well trained, and there might be a ceiling effect that they can't be better. So if we are doing an RCT here with the youngsters, that's possible to do. It's difficult, of course, to run an RCT, but it's definitely possible. We have shown this. And there you can get a dramatic difference between the groups. If you have the control groups here in the blue line, and from the beginning you have no knee injuries at all, 100% are healthy, and then the lines diverge here, so you can get a dramatic injury reduction in this cohort. However, and see the scale on the y-axis is not the same here, but the lines might diverge a little bit in elite, well-trained players, but probably not very significantly. We have shown a few years ago in our study that the injury rates actually were stable, that is, they were unchanged from 2001 to 2013. And that might look pessimistic at first sight. We all want to see an injury preventive effect, that the injury rates go down as a credit for our own work. But we also know that the style of playing football has changed, the game intensity has increased, so maybe we can just flip the coin and say, yeah, we need to be happy that the injury rates have not increased. Yesterday I talked a little bit of this first box, and now I will concentrate more on the second box, because knowledge on the underlying risk factors and also the injury mechanism is really a key factor when you try to go to prevention. The third and fourth boxes here. And this is a list of traditional risk factors for any injury, not only ACL injury, and could be for hamstring injuries as well, where you have intrinsic and extrinsic risk factors, and you can also classify them as non-modifiable and modifiable. And when you're talking about an elite injury setting, I think we need to go a little bit from the traditional player-related intrinsic risk factors such as muscle strength and joint flexibility and fitness level and so on. We need to look at other factors, and maybe not in football. We cannot change the rules. We cannot forbid player contact, for example. We cannot brace the knees of every football player. So we need to look at some other factors, and every speaker has touched on these areas before, and I would just put this circle around the psychological factors and the workload and congestion problems here. And especially if you link it to a history of previous injury, because I said yesterday that match play, sex or gender, and age are the most important risk factors for ACL injury if you talk about the index injury, but we also know that previous injury is really an important risk factor. And for most injuries, ACLs, knee injuries, hamstrings, the number needed to treat is most often much lower when you're talking about re-injuries than index injuries. So we really might need to target the recurrent injuries more in this aspect. You've seen this video clip before. And me and Claire, we actually wrote a few lines in the Qatar journal, the Qatar Sports Medicine Journal this summer, I think, about having the Zlatan case as the fictive scenario, where where's Christian? That was exactly what he said. This is the the interview by Zlatan this summer when he admitted that I was not ready. I don't know if he means both physically and mentally here, but he was obviously not ready when he came back in November after his ACL injury. He admitted that later. And just 1 week before he appeared on the bench against Newcastle, I spoke to Rickard Dahlman, the physio, you know him, and he said to me, no, Zlatan is not even close to return to play. And then 1 week later, he got 23 minutes on the pitch. So I don't know the details here, but I crossed my fingers actually hoping that he shouldn't return, because if we had waited for maybe 9 months, our job would have been so much easier when we were speaking to our common patients. Because now everyone wants to be like Zlatan, and I think that's a problem. But this is a hot topic at the moment, that about workload monitoring and management. And there are some general data on sports injuries, no ACL-specific injury data yet. But it might be that there is an inadequate preparation for the demands of the sport when the athletes go back to the field or pitch or whatever. And we don't have any really good explanation why so many graft ruptures actually occur in the early window after RTP. So I like this framework, and it's tempted to see that we know that acute spikes in load are unfavorably associated with injury from an overall perspective. So therefore we suggest that you need to monitor the load, and you also need to manage the load. It's not enough just to record it, you also need to make changes and make adaptations if you think it's too high. And you need to start already at latest in the transition zone from final rehab to RTP. So it's too late if you start recording it after RTP. You need to do it really in the final phase of the rehab and calculate the so-called acute to chronic workload ratio to see that you don't get these spikes in load when they return, because this might have a negative effect. And personally, I believe there could be something here in the problem with early ACL injuries. So, to conclude, when we're talking about injury prevention, we really must acknowledge that talking about non-elite athletes and elite athletes, this is not the same. It's two completely different populations, and we must think a little bit different here. Elite players, they are in general so well-trained already, so you can just not hand out a neuromuscular training program to them and expect very dramatic improvements. I think we should focus very much on the re-injuries, because the number needed to treat is much lower than trying to prevent the index injuries. If you're thinking of an elite setting, we really need to leave the conventional risk factors a little bit behind and go into the jungle with the workload and psychological factors. So we definitely need more studies here, and until we know more, I would recommend you to monitor the load and try to avoid spikes in load after return to play. And there are a lot of good congresses out there. 2020, there will be a new conference in Monaco. I recommend you to go to that conference. There is always a complete program covering all the body, and there's also a great social program, so we will have a lot of fun if we meet in Monaco. Thank you very much.
Thank you very much, Marcus. And we will have Grete to sum up the key elements regarding prevention. And after the speech, we will have a discussion session, so you have to think of at least one question each. And I will walk around the audience and let you ask your questions.
You're not going to hear everything once more, so can you get me to the bottom? Where I was let you go. Right. Ja, skal den her på det siste. Oh, we are ready. Okay, trying to sum up these three talks is maybe the easiest way is to just show the take-homes. And I think Martin's is really clear. Neuromuscular training works. So we should use it, and if we include Marcus' talks as well, I think it's for the young athletes and those at lower level. I think we as a group is very important because they don't have the support by professional physical therapists and physicians follow the athletes all the time, because that's the case in the top level national teams and the top level football teams. So they have people around them all the time which can take care of this primary and secondary prevention. But the life out there is that it's actually we as maybe parents and aunts and uncles who can go out and help the teams in different sports and try to implement the neuromuscular training programs which are out there. So I think this is so important. We need to do it because the problem is that we do good research, the number of injuries go down, there's a lot of talk about it, and then people forget it. So how can we get this knowledge out to be there for all the time until new knowledge gets out? And as Martin said, we need to limit the number of games with senior teams. And maybe report minor complaints which we can act on and reduce the number of training and get this rehabilitated well. And monitor workload, well-being and health, and be prepared to act on that information. And then we have just heard Marcus, and I think, as he said, there are differences between elite and non-elite. And that's my point, that we need to take care of those who are not the top level, because they don't have a professional people around them all the time. He wants us to take care of also the psychological part, and also take care about the workload, be aware of that. And of course, it's maybe easier to prevent the re-injuries, but I don't think we should forget trying to prevent the first one. I think that's extremely important, because that's where we can act on the young athletes. And I repeat this, my take homes again. It works to do these prevention programs, to have some restriction on the number of matches or teams the players are acting on, monitor the workload, so they're not having too tight schedules all the week with a lot of matches, a lot of training, no time to do their homework, no time to rest and get good food. And I think it's so important that we really get coach education and cooperation. And in Norway, we really cooperate very well with the Handball Federation, and we have courses with the seminars with the coaches, and teach them all this stuff, and repeat and repeat and repeat, because we need to learn all the new coaches that come up there. And there are a lot of parents coaching their children, and we need to teach the parents and all the new coaches coming into the sport all the time. So you have really a job to do. Go out and get this knowledge out, and don't forget that we have help with the apps that can give you all the information about the exercises, and you can also give that app to the patients. It's really helpful for them and also to the coaches. So with this, I think we maybe have a break, Roland, or what do you think? A small break? I hope you're really, I know you're coming with all the questions, don't you?
Yeah. No breaks. No breaks. We'll please have all the speakers up on stage. And we will start with questions regarding prevention. So, and then we will open up for any topic on ACL.
I have a story to share first.
Go ahead, Eric.
I asked for permission about the story. It's from Axel, who's in the back here. Just wave your hand, Axel. And it's about the Zlatan effect. Axel had a patient a few weeks ago who had 2 or 3 ligament re-tears after ligament reconstruction of the shoulder. And the patient had been pushing things a bit too hard, but he wasn't worried because everybody knows lions heal quicker than humans, right? Exactly what the patient said.
Well, that's the way we should think. What about all the slides that's been showing here on this Congress? How do the audience get hold of those? Eric?
So what we're going to do, tomorrow I'm going to send an email to all the speakers, and they will have 24 hours to send us PDFs of what they want to share. After that, we will all send you a link where you can download all the files. So you will have these next week sometime.
Is that okay with you? Yeah. Now, prevention. Do we have any questions from the audience to the prevention people?
I have one.
Yeah, there's one. Go ahead.
Is this on? Yes, I have a question about prevention and, of course, psychological factors. And I wonder, we all know that knee self-efficacy is important because after an injury, clearly there is a difference between those who do good and those who do bad. But shouldn't we do so that patients feel like lions before they are patients? Shouldn't we integrate, for example, self-efficacy as a prevention as well? So not just physical prevention, but psychological prevention as well.
Any comments on that?
Yeah, please, Claire. I don't really have a comment on that lion issue.
I'm not going to comment on the lion issue either, but I will say that up in Halmstad, there's some people doing research looking at the relationship between psychological factors and getting the injury in the first place, and also doing work on what kinds of interventions. So the biggest problem that we have at the moment is that we don't have very many interventions. So it's hard to know. We can identify people who we think might be at risk or have some problems, but we're limited a little bit in what we can offer them specifically with evidence-based interventions. So I think this stuff is coming because we find that particularly stress is really quite strongly related to injury, getting the injury in the first place. So if we can do things like mindfulness, meditation, relaxation training, perhaps these kinds of quite simple things where patients can download apps and do these kinds of things on their own at home. Mental training, a lot of athletes know how to do mental training. These might be some quite simple interventions that you can try, low cost, relatively short amount of time investment, and I don't think there's any evidence of harm. So it's that kind of age old, if it's not going to do any harm, then maybe we just try it and see.
can just comment very generally. I don't think sometimes even more simple things will get us quite far. Just being prepared to be a little bit perceptive about how the athletes feel. Do they have a lot of stress in their life at the moment? Is something happening in the family? Is a lot of stuff going on at school, with friends, whatever? Something just doesn't feel right. Then you don't feel sharp. If you can just monitor that with simple questions and just being perceptive as a parental coach, as a physio, or whatever, I think we can get very far with those sort of simple things, not being psychologists or using very sort of complicated techniques.
For self-efficacy, it's been well described how you strengthen an individual's self-efficacy beliefs. The three main steps. The most important one is what you say and how you say it. If you say, I think this is going to be okay, you send a signal that it's not going to be okay. So be very positive, optimistic, but realistic. That's step one. Step number two is make sure the individual with low self-efficacy gets tasks or exercises that they can succeed in. If you're successful in what you do, take a small step at each time, and you realize, I can do this. It's going to strengthen your self-efficacy belief. If you give them too tough tasks and they're not successful, they're going to just fall down again. So small steps and have them succeed. And you're doing this, and physios are professionals in doing that. The third step is to have other successful athletes that's been on rehab for half a year longer, that are successful, so they can get role models to look up to. Maybe not Zlatan. And like Marcus said, we're glad he didn't return before 9 months. But it's good to have positive role models, and that will strengthen your self-efficacy beliefs.
If we stay on that topic, can there be a problem where we have patients that have too much self-efficacy?
Anyone want to answer? We have had that discussion. Is Pia still here? In her thesis, we discussed this, and according to the theory, old theory by Bandura, you can't have too high self-efficacy, because then you're out of line. But athletes are out of line sometimes, and we have had this discussion again with the youngsters, because they seem to have a higher self-efficacy, and they go back too early to sports. So maybe there's something in there. And again, you have to be realistic with the youngsters and give them good information. What do you say, Susanne? We've been discussing this a lot. Can they have too high self-efficacy?
I think I missed your discussion because I talked to another. But your question is if young athletes can have too high?
Yeah. Is that dangerous? Do they injure themselves?
I think that could be some reasons, yes, to think that even if you have too high self-efficacy or maybe we get fooled if they are to score too high on psychological readiness and have high goals and motivation that they seems to be ready, but they are not maybe physical ready. But as I said before, they are very this risk thinking. They are not mature in their risk decisions.
What is the podium here? You meet a lot of elite athletes. Do they have too high motivation, no barriers, and they just jump off the cliff? Marcus? Grete?
I think those who are most motivated and maybe live for the sport, they can do whatever necessary to just come back and as early as possible, and that's why we are so important to just slow down a little bit, keep them in a rope and kick them back so they are not allowed to go further. I think it's important.
Yeah.
We have an important role there.
Marcus?
I mainly work with handball players now at the moment on the elite side, but I don't think the players are a problem, but the coach is a problem. You really need to do the work with the coach, but the players are quite fine, I think.
And that is a characteristic of a person that has high self-efficacy beliefs. He comes to you and asks, just tell me what to do and I'll do it. And if we give them good guidelines, they're going to stay on the path and hopefully not go back to her. But then we have the coaches. Susan, you had the question, or the audience? What do you say?
Can I just
Go ahead, Martin.
go on a little bit about that self-efficacy issue? One thing that we've seen, and moving away from patients as well, one thing that we've seen in using these types of prevention programs is that when we interviewed coaches, this was from a PhD student of mine, Anna Lindblom, she found that coaches who said that they had high self-efficacy in sort of feeling in control of using these programs. I can manage these programs, I feel I know what to do, I can use them with my players, and if the players complain a little bit, I have good sort of things to say on why this is important. You have high self-efficacy to really do this. Then they were more likely to adopt these programs and more likely to maintain using them over time. So we have to remember that most of the coaches among the youth teams, they are parental coaches, and they have zero education in how the body works and maybe not even in training. So we have to have some kind of simple interventions and simple techniques or teaching them how to use these programs, or maybe even to monitor workload and monitor health and so on. So I think sort of feeling in control and feeling confident that I can actually use this in a good way is the key issue to help the youngsters through the coaches.
Yeah, I've been working with the Swedish national, whatever, Riksidrottsförbundet a couple of years ago, and we identified that there is about 300,000 coaches, parents, and previous athletes that are coaches. And they stay with their own kids until approximately 5 years, and then there's 300,000 new parents, coaches coming in. So what you're saying, we have to find a simple way. The Skadefri home site or similar things like that, that the new parents, coaches, previous athletes can take care of all the information we have.
Yeah, I'll deal with you soon. I mean, there has to be a continuous work. We cannot do this just once and then see it sort of go on. We have to do this over and over and over again because there's new coaches, there's new parental coaches coming in. And we need to make this sort of an integral part of the club organization. Whenever there's new coaches coming in, they should have an education in knee control or 11 plus or whatever program you use in that sport. It has to be something continuously going on. It should be within the walls of the organization, the förening, that you have to have these courses regularly.
I just have one question to all of you. Are you more inspired to do some prevention work now, or will you continue as always? Because I think that's a problem with all of us. We go on the seminar and we learn something, and we don't always take it with us. And if you want to change something, what will you do? Could someone say something about that?
First, we will have the first question first. It's really boosting for everybody. How many are more eager now after this conference to do some little better prevention work? Hands up. See? It's good. And then the next question, what will you do? You had your hand up here. What will you do? Yeah. Or your neighbor? Anyone there? Just give us something. Anyone? What can we do? Here is hands are up. One there and one up here and one in the last row.
I have a question. You hear me? I have done some prevention jobs in clubs, and I miss. We don't have a special organization for the prevention. That's a big problem. You said you have to do the prevention. okay, but it's a lot of jobs doing this. And we have to do it the same because the parents, trainers, they don't see it the way we do. So, I miss a national organization for prevention. We have to create an organization for that. That's what I think.
Comment from the podium? Marcus?
Yeah, I think personally I agree. It would be good if the Swedish Sports Confederation, Roland, took a major step here because many of the how do you say, the sports associations, they are very small. And it's quite easy to work with football. It's a little bit more difficult to work with handball, and it's perhaps even more difficult to work with floorball. And we should think of wrestling and so on. So I think it's a good idea that the umbrella organizations, the Swedish Sports Confederation, can do a little bit more here. Yeah.
Question here?
Well, I think it's like Greg talked about, use the time for warm-up more with quality and just don't jog around or kick a football, especially in handball, because handball players always want to be football players secretly. But I think I read about a lot of the 11 plus FIFA program. Have you tried it in handball? I know it's also been tried in the NBA with good results. Do you have any experience of it in handball?
Well, actually, we have a similar program made. The youth program I showed you is more or less the same. It's running exercises, strength, balance, and everything. So we have a handball program, but I think you can mix the handball program with 11 plus, the connect control. It's just mixing the exercises, but try to have touch upon running, balance, coordination, and strength, and also some agility to do something with. So you can just mix all these exercises, but be a little bit concrete on what you want to achieve. So you pick exercises from the different programs to make it more funny, to change a little bit so that they are there.
Well, question there, comment?
This is not perhaps a question, more of a good concern, and perhaps from you as a parent. The incidence with ACL injury, are you seeing some trends that it's getting in younger ages? Or, and then I thought perhaps the prevention starts too late.
I'm sorry, can you repeat that question?
The incidence of ACL injuries, are there any tendencies that the ages are younger?
Is that true?
There's some the biggest registry studies that we have come from Australia, and they were published at the beginning of this year or late last year, so it's quite new. And it seems that the numbers in very young children, so before puberty, is increasing. But it's hard to know if that's just that they're being diagnosed more and picked up more, or if there really are more. It's probably a mix of both, because we also have this trend to earlier sports specialisation in younger and younger children, and it seems that that might be linked with more ACL injuries and more meniscus injuries as well. So not only, the point I wanted to stress is that we're talking a lot about ACL, but not to forget about the other injuries to the knee, particularly the meniscus, because that's probably the most important structure for osteoarthritis risk in the future. So it's more, if you injure the meniscus, you have a higher risk of osteoarthritis than you do if you only injure the ACL. But yeah, so in the younger children, it seems like the numbers are increasing. It's hard to know exactly why.
So the prevention program should start earlier, as you suggested? Question mark?
I just want to add sort of a Swedish touch to that as well, because Malin Norman just finished her PhD in Stockholm. She looked at this, me and Marcus were also involved in that, through the Folksam registry. And Folksam has a registry, they have the insurance for more than 60 of the biggest sports. So we looked, and this is also to empower all of you guys who have worked with knee control out in the clubs for many, many years now, is that when we looked at the number of reported knee injuries, acute knee injuries and ACL injuries to the Folksam insurance company, the 5 years before the sort of implementation of knee control began in Swedish football in 2010. So the 5 years before that and the 5 years after, there has been a decrease in the number of reported acute knee injuries with 20% overall, and for ACL injuries by 13%. So we definitely see a real-world impact when all of us and all of you guys have been working with knee control and trying to get that out into Swedish football and the youngsters. So even though we see negative trends in Australia, we actually see quite positive trends in Sweden in football, the biggest sport. So we can do something, and it works.
What would you say is the ages that has fairly good prevention programs and do that at a regular basis? The 50 years old or 12 years old? Or?
I think the stats Martin mentioned is from 12 years of age in the Folksam Insurance database, but they have, the FIFA has developed a Kids 11 Plus program now, which is basically the same principles, and they have tested it from an overall injury prevention point of view and found similar results as in adolescents. So you can start already from the age of 7.
Yeah, I have a question
Go ahead,
that's
Mayor.
partially answered, but I'm interested in the load management part of it and the early specialization for children, because you can see a spike somewhere in between 14 and 15 years old, and that's the time where people choose one sport. And another thing that I've been thinking about is like injury prevention things. Is that a thing just to reduce intensity in the training sessions and just lower the total load on a training session and just take out of more, have a bigger like variety when you do things in one training session and reduce load and intensity?
What do you say about that? You say that the total load over a week or a month is sometimes or often very high. What about each individual session? Can the intensity be high? Any comment on that?
I think the intensity should be high, because that's also shown regarding load that you need to keep the intensity high. But I think when you look for several weeks, they have to have a wise control of the load, so you are not on the top level of load all the time. You have to, consistency. So you had a lot of good comments, but the rest can be more.
But there is a rule of thumb, tumregel, that's the same word in English, right? Rule of thumb. That if you have a really, really heavy workout, strength or endurance or technique for that matter, it takes at least 3 days to recover safely. So that means you can have 2 heavy workouts per week.
Another part of that, I think the third part of your question was about early sports specialization. And to be honest, the data that we have today is not very strong to really show that this is a problem. There are someone has said that early sports specialization can be negative in terms of more obvious injuries, but it's not really strong data. So at the moment, we don't really have evidence that this is a problem. And I think we can flip that around to say that in most of the sports, we have the option to actually have a varied training. You don't only have to do that sort of repetitive kind of training. You can mix in other things. You don't have to change sports. You can just mix in other ways of training to get more sort of whole body training and varied training. So at the moment, there's really no evidence to suggest that you have to participate in many sports. I think that came from sort of specialization from a performance point of view, but we also sort of try to link that into more injuries, but there's no strong data to really show that this is the case at the moment.
So if the, sorry, I'm kind
Go ahead.
So if the podium has to choose what the coaches and trainers out there have to learn first, is it load management or injury prevention programs?
Same thing, huh?
I think they are so close, so, but I will of course say injury prevention. But I think load is a part of injury prevention, so I think it's two parts of the same.
Okay. Andreas?
I mean, the easy answer is if you don't load the athlete at all, then he or she won't get an injury. So I mean, sure, but that's not very fun.
Yes. I would like to hear your thoughts about the secondary prevention. And we got a patient that we cleared and has been in the sports for a year or something. What's your thoughts? Should that person be doing even more, or is the injury programs enough? Or what's your thoughts on the long-term secondary prevention?
Often I believe this is also a matter of compliance, because they need to do the lifelong. If you have had an ACL injury, you need to do these exercises lifelong. But they go back to sports, they don't have time, so the compliance will diminish over time. So I think that might also be a reason why they re-rupture 1 year after they have gone back to sport, because they are not doing the exercises as they should.
And as I showed yesterday, that the plan when you are going back, after you are going back to your team, you have to have set days for doing the strength and balance training. You can't just do the football training or handball training, you also have some time for just both strength and balance. And I also think that if you have had an ACL injury, there are prevention programs out there, then the patient has to learn that and take it back to her or his team and use it for the whole team. Try to get this knowledge out for everyone. So it's nothing special thing that we do. It's just a part of warm-up or training. It's not a special exercise. It's performance enhancement.
Christian? Yeah. I would add, I think one of the things we have to do better is understanding where the epidemic is. So if we talk about ACL injuries and we talk about kids being 10, 11 years old, there's no epidemic. There's lots of knee pain starting, but there's no ACL injury. If we go to greatest handball players, that's an epidemic. And that's where you really have to do something, and Greta has shown that you can do something. And so I think we should move from a very generalized approach, a warm-up approach, and then probably what we need to do better is become very, very specific in relation to specific epidemics. And that's why it becomes very, very difficult to say what we should do on a broad spectrum, because it relates to sports, it relates to populations, and it relates to where the epidemic is. So that, I think I would like to add that. And I think that's what you did, Greta, was really, really important, because you really targeted what I think is an epidemic. We don't know at the elite level in football, women's football, whether these programs work, and we have a real epidemic there.
Any comment on that, podium?
No, I agree. We have to really take those at really high risk and handle it was the females, because the male handball players doesn't have a lot of ACL injuries, much lower than the male football. So it's not a problem among the male players. It's a female player, and we see it in even younger and younger female handball players. So we really have to go up there early and start doing this type of training.
More questions from the audience? Comments? Thoughts? It's survey time again. How many of you up here do have an ACL injury? A couple. But you're doing good. You're doing good, really good in golf. So you had a golf ACL reconstruction? Yeah. And she plays on elite level after 3 surgeries? Yeah, very good. And to have the injuries is a very tough course to go through. You have to injure yourself and then surgery and then rehab. But you learn a lot. Oh, you do. Successfully. Yes.
Or you don't operate. Or you don't operate yourself.
How many of you have an ACL injury and is not reconstructed? Hands up. Look at Putin. They don't believe in surgery, obviously. Okay, more questions, Eric, Susan? Here's one, go ahead.
What's your thoughts on use of knee brace after a knee injury? overall. I have a lot of players in my team that ask me after if they can have a knee brace or they need one.
For MCL injuries, of course, yes, a brace 4 to 6 weeks is the rule, I think, but for ACL injuries, we don't use braces in Norway, as I know. Some won't use it if they don't reconstruct, and I'm going back, maybe do some downhill skiing, but that's not for really return to sport. They don't use braces.
It also depends a little bit on the sport. It's not allowed to use a hinged knee brace in elite football, for example. But you can use some type of braces in handball, but not all of them are approved. So it depends a little bit on the type of brace and the type of sport.
Yeah, because a lot of them just want one after they are evaluated and go full force in the sports again. But so you don't think they need one for life because a lot of them wants to have one.
I think the only evidence we have at the moment is that the knee brace can protect against MCL injuries in American football, but for other sports there is no evidence at all at the moment.
Anyone else? Go ahead.
Can an ACL reconstruction be seen as a prevention for osteoarthritis to diminish the risk in future? It's common. There's no difference when you operate or...
It's the injury itself. Yeah. It's the injury itself.
And it's really it's not the ACL that is linked to the OA, it's the meniscus injuries and the chondral injuries, but particularly the meniscus. So when you look at the best quality studies and you look at the ones where they've said that the patients have isolated ACL injuries, the rate of osteoarthritis is 10-15%. But when you look at the studies where they had patients with ACL injuries plus meniscus or chondral injuries, that's when you get OA rates up to 50%. So it's really about protecting the meniscus and doing as much as we possibly can to protect the meniscus and the chondral surface. And we can not be so, the thinking of we have to reconstruct the ligament because it stabilizes the knee, that's not, it's just not borne out by the research.
Do you recommend a meniscus operation then?
That's one of the reasons that they suture the meniscus. But some athletes don't want to do that because it takes a longer rehab. But you should always say that they should suture if it's possible.
There's a question up there. Go ahead.
If I can just say a few words,
Go ahead.
we also need to it's the medial and the lateral meniscus are not the same. So you really should try to repair the medial meniscus if you're doing an ACL reconstruction. The lateral, you don't need to think very much about that. You can actually leave quite much on the lateral side, but try to do the repair if you have a concomitant medial meniscus tear.
Does that apply also to the general
You
population?
need a microphone, otherwise we can't hear you.
Yeah, this is from the register, so it's for all ACL patients actually.
Okay, question?
We have the Mats Britta here, Professor Mats Britta. He's the
Can I ask my question now? Sorry.
Do you ask your question first?
Thank you. I work a lot with alpine skiing and ski cross, and we work on an international level to make the courses safer for the athletes. And I wonder if you think your sports are too rigid in their format. Is there any possibility to make the sport more safe for the athlete than to do the prevention the other way?
I'll make it start off because people here are far more expert than I. This has been a debate in Australia really recently because they introduced women's AFL. So for those who are not familiar with Australian football, it's full contact. They don't wear body protection. There's tackling. It's on a big field, and it's a really wonderful game. I love it. And women were there's been women for so many years who wanted to play and were never able to past about 15 years because they were not allowed to play with the boys and there was no women's competition. And they introduced a women's competition in the summer months, 3 seasons ago, and there was huge worry that these women were going to get ACL injuries, and they have seen quite a few ACL injuries, and one of the responses of the governing body was to say, we have to make the season shorter. Part of the problem was that these were athletes who were paid to play in very short seasons, so it started off as 10 weeks, but they all had full-time jobs because you can't be a professional athlete getting paid, 5,000 Australian dollars for a 10-week season. You have to have a job outside of that. So they were paid for 9 hours per week. So you can't do enough training to perform and to stay injury-free for that amount of time. So they have to make the game more professional, and the governing body is saying, we're going to reduce the time, reduce the time, reduce the time. So it's a really great point, I think, that the organisations and the governing bodies of the sports have to be serious about protecting the health of the athletes. So now I'm going to let others who know more about this comment.
I can just take, I think that's a very good point to make, because there's certainly many ways we can work to sort of reduce the number of injuries. And if we take one example of head injuries and concussions, for example, there's some really good examples, for instance, where we try to change the rules of the game and how you enforce the rules as a referee. For instance, if you go out in football and you do a heading, you're not allowed anymore to bring up your arms below above shoulder height. You can get a yellow card or even direct red card for those kind of incidents. And we've seen that that has managed to reduce the number of head injuries in those kind of elbow to head situations, for instance. Maybe not so successful example is from the US, where they said you cannot do headings in football as a child. If that will reduce the number of concussions, we really don't know. The evidence base for that intervention is not very strong. But it has raised the riots in the football community that this is changing the game totally. You cannot do headings from a corner, for instance. It's not football anymore, it's something else. Or it's headball, I don't know. But it's difficult to sort of change the rules of the game or change the nature the game works without sort of making it another sport. So there's some interventions that are very possible to do, but others might be too much. Even the approach to try to reduce injuries, it changes the sport too much.
Okay, thank you very much. We'd like to introduce Professor Mats Brittberg. He just arrived, and he's one of the world leaders on cartilage injuries and arthrosis. So Mats, what would you say that we can do as surgeons and physiotherapists to prevent the long-term arthrosis that all the ACL injured are prone to get? Can they do something like 2 years, 5 years after they finish their career? Can they do something there to prevent future arthrosis problems?
That's certainly a very difficult question to give a full answer on, as I didn't hear from what you discussed before, so I've just dropped in a couple of minutes ago. But I could say that there is a very nice paper by Span and Hoffman. They looked upon cartilage injuries in patients and followed the patients for 10 years. And 1/3 of those patients with cartilage injuries, it was no ligament injuries, but just cartilage injuries. 1/3 of them developed osteoarthritis, and if you looked upon those patients that really were the ones that developed it, were patients with overweight. It was also, unfortunately, female gainer, meniscal loss. But the strongest indicator for progression into osteoarthritis was the cartilage lesion on the tibial plateau, which was a little astonishing for me, because most often we notice the cartilage injuries on the femoral condyle. So that was patients without ligament injuries, and when you put a ligament on top of that, that could certainly have a further development of osteoarthritis. But I think certainly genetics is important. The way that, for example, ACL surgery, the way that you do the surgery could influence it. But for me, one of the strongest thing is to look upon the meniscus, and you know, nowadays it's a tendency that we do preservation of the joint. So before we took away the meniscus, today it's very important that we try to save the meniscus, and even in elderly patients, in order to avoid further progression into osteoarthritis. And then when you think about that paper that said that the strongest factor to influence the progression into osteoarthritis was a tibial plateau lesion, then you could think upon the importance of the meniscus. So the meniscus is something that is maybe more important than ACL surgery in the future. That's what I think you could think about.
Thank you, Mats. We're going to hear more from Mats later on this afternoon. I heard one modifiable factor there, and that's a recommendation to all of us. Don't gain weight after you finish your career. That's easy. Okay, I think time is up here, eh? What's next? We take a short break?
Short break, stand up, but I'll tell you what you will be doing afterwards right now. So there will be 2 workshops.
Thank you very much, speakers.
Yeah, thank you very much, speakers. So there will be 2 workshops. One of them will be in here with Claire on return to sports. So you'll be sitting here instead of on stage. Greta, how much space do you need? Not so much. So anybody or everybody who wants to go and do an injury prevention workshop, you go, I'll stand there. This way.